So with that, I would like to introduce the first speaker of this meeting. So this is James Blewett. James is a senior clinical lecturer and an honorary consultant in rheumatology at the University of Manchester. He has a special interest in interventions to improve treatment response in inflammatory arthritis and is an experienced chief investigator. In 2016, he completed his PhD, investigating methotrexate adherence in rheumatoid arthritis and the genetics of methotrexate pneumonitis. And he oversees a large multi-center observational psoriatic arthritis study, and he has presented his research at national and international conferences, and he has collaborated internationally. So with that, I would like to welcome James to share your slides with us.
Thanks so much, Elizabeth. Can you hear me?
Yes, very well.
Oh, great. Thanks so much. 2016 sounds like such a long time ago now. I need to remove that part of it. But anyway, good afternoon, everyone. Thank you for joining us for this webinar. My name's James Blewett. As you've heard, I'm a senior clinical lecturer and a rheumatologist at the University of Manchester in the UK. And I'm going to give a brief overview of the immune-mediated inflammatory diseases with a real particular emphasis on my specialty, on rheumatology. These are my conflicts. So, IMIDs are really heterogeneous diseases that have different target organs, such as the joint or the skin, and they often share a common inflammatory pathway, and a common theme of the diseases are an increase in pro-inflammatory cytokines. Unfortunately, the diseases are often chronic and incurable, but with some fantastic new medicines, they are treatable. So why? Oh, I have an error. There we go. Hopefully that'll clear. Okay, I'll carry on. So a wide variety of these IMIDs are described with different target organs. So it includes the gut in inflammatory bowel disease, the joints in psoriatic rheumatoid arthritis, and the spine in axial spondyloarthritis, and the skin in psoriasis, multi-system in the case of lupus, and neurological with multiple sclerosis. Taken together, IMIDs affect up to 7% of the Western world, and the majority of these affect women more than men. It's not clear why this may be. One theory is that female sex hormones may promote inflammation, but there are certainly some exceptions, such as in psoriasis, where we see it's roughly equal between women and men. The diseases are often regarded as complex genetic diseases. And what this means is that these are diseases whereby there's not one genetic variant that causes the disease, but multiple variants in our DNA that predisposes to an increased risk of developing the disease. And then the diseases often need a further trigger, which might be environmental. This then leads to a loss of immune tolerance so that the immune system attacks the target organ, such as the joints, causing an immunoinflammatory reaction. We can now study these diseases to explore their underlying genetic mechanism by undertaking studies such as genome-wide association studies. So these are huge, large-scale studies of patients with and without the disease, so that we can compare genetic variation in those with the disease to healthy controls. Often, the main regions for susceptibility of the IMIDs are within the HLA genes. HLA genes code for proteins that interact with the immune system so that we can discriminate self from non-self, and they bind proteins and present them to the immune system. So with this loss of immune tolerance, you can see how important HLA molecules are in IMIDs. HLA genes are encoded on chromosome 6, and they include class 1, which are on the membrane of nucleated cells, and class 2 present on the antigen-presenting cells, such as dendritic cells and B cells. Their expression can be induced during inflammation. And on the right, what we've got is a diagram of the HLA protein, which is almost like a claw, where within the claw, in between these corkscrew-like structures, are proteins that HLA is presenting to the immune system. And there's strong association across the IMIDs in HLA variants and the risk of developing the disease. So by way of example, rheumatoid arthritis is a chronic inflammatory joint disease affecting 1% of the adult population, but it also affects other organs such as the lung. Having a better understanding of the disease process can lead to development of new and novel drugs with improved prognosis and aim for remission. And the disease is often associated with autoantibodies to IgG. We call this seropositive disease, when a patient has rheumatoid factor or antibodies to citrullinated proteins or ACPA. So RA affects 1 in 100, but it is higher in certain populations, such as Native Americans. And the peak onset of this disease is in the 40s to 50s, but often there's a delayed presentation to the doctor. We see that the incidence increases with age to the 70s, and it has roughly an annual incidence of 14 to 36 per 100,000, depending on gender. And when we investigate the genetics of rheumatoid arthritis, we see a real strong heritability with twin studies where we compare identical and non-identical twins, showing 60% of the disease may be due to our genetics. And now we've seen that there's more than 100 variants associated with the disease risk. And one of the strongest associations is regarded as the shared epitope. So the shared epitope is a 5 amino acid sequence on HLA DRB1 chains. And there's a dosage effect whereby if you have 2 copies and have rheumatoid arthritis, you're more likely to have more severe disease. And it's responsible for up to half of the genetic component of rheumatoid arthritis and is more associated with seropositive disease. So those patients who have rheumatoid factor or ACPA positive disease rather than seronegative. So as further examples in IMIDs, we see that HLA-B27 is associated with psoriatic arthritis in 20% of patients, and also 25% with inflammatory bowel disease. But these gene associations can highlight differences within a disease, such as the shared epitope, with increased association with seropositive compared to seronegative. And in the future, we may be able to define subtypes or endotypes of disease. So for example, TNF-AIP3 genetic variants and seropositive rheumatoid arthritis. So this may, in the future, redefine what we call rheumatoid arthritis based on our underlying genetics. So going back to our definition of these complex genetic diseases, the genetic variations on their own are not enough to cause the disease alone. So there must be an environmental trigger that increases the risk of disease, leading to this loss of immune tolerance. So using the example of rheumatoid arthritis, we all have a microbiome. So this is the collection of microbes that live on and inside us. And we see that gum disease can be linked to a type of bacteria called gingivalis that causes conversion of amino acids, arginine to citrullinine, which we call citrullination. This may then promote antibody development, so antibodies against these citrullinated proteins, which are these ACPA antibodies, and these are key diagnostic or classification biomarkers for seropositive rheumatoid disease. And they're also associated with development of psoriasis, these citrullinated antibodies. Another example of environmental risk factors in rheumatoid is smoking, which doubles the risk of rheumatoid arthritis and is associated with inflammatory back disease and Crohn's. And finally, I found this really interesting. Dust inhalation may also increase the risk of autoimmune diseases. One such example is following the 2001 World Trade Center attack in New York, which saw firefighters following the attack had an increased risk of developing autoimmune diseases, including rheumatoid arthritis. And dust includes pulverized cement, silica, asbestos, glass fiber. So I'd like to move from etiology to pathogenesis of the IMIDs, and we see that there is an underlying immune system dysfunction that leads to a loss of self-tolerance and a pro-inflammatory response. The exact profile of this pro-inflammatory response and the cytokines varies by disease, and therefore we see that targeted treatments for one disease do not necessarily work for all of the IMIDs. So a good example for this is non-steroid or anti-inflammatory drugs help to reduce inflammation in rheumatoid arthritis, but can actually worsen the disease in inflammatory bowel disease. What's fantastic now are these more advanced therapies that have really revolutionized treatment for IMID diseases. TNF-alpha is a pro-inflammatory cytokine that causes activation and migration of inflammatory cells and production of degrading enzymes that leads to tissue injury. TNF-alpha is really implicated in a number of IMIDs, such as inflammatory bowel disease, rheumatoid arthritis, and psoriatic arthritis. And we see a number of other cytokines across the IMIDs that are increased and important pathways, particularly JAK-STAT pathway in inflammatory bowel disease, rheumatoid, and psoriatic, but also some unique pathways such as PDE4 in PSA and in rheumatoid CD20. So we've looked at a brief look at these cytokines that we can now target, and I'm going to move on later about how we manage and how we use some of those advanced therapies. But before I do, what are the possible complications of having an IMID? Well, we see that there is an increased risk of cancers across many of the IMIDs. For example, psoriasis is associated with an increased overall risk, but we do know that there's confounding factors such as smoking and obesity that may also increase the risk of cancer and also the disease such as rheumatoid arthritis. Inflammatory bowel disease has an increased risk of colorectal cancer, but there are these confounding factors that need to be taken into account. There's also a greater risk of developing another IMID. So for example, in inflammatory back disease, ankylosing spondylitis, about 40% of people also have inflammation of a part of the eye, the iris. And this disease also increases the risk of inflammatory bowel disease in a relative by up to 8 times. And we see that up to 75% of people with rheumatoid arthritis live with a multi-morbidity, so 2 or more long-term conditions. As an example, there's an increased risk of cardiovascular disease in rheumatoid arthritis, so 3 times the risk of heart disease compared to those without rheumatoid arthritis. As well as an increased risk of infection that we see as well. So we see that active inflammatory diseases increase the risk of hospitalization for infection, and this hasn't fully been explained by the treatment that we give that acts as immunosuppressant therapy. So I would say that multimorbidity is really a significant issue for patients living with IMIDs, with conditions such as insulin resistance, obesity, changes in their lipids, and high blood pressure. However, what's fantastic is that successful treatment of some of the IMIDs actually reduces the risk of cardiovascular disease. So this really highlights that whilst helping to reduce the inflammation helps to reduce the chance of cardiovascular disease as well. So how do we manage these conditions? So I'm going to focus on rheumatoid arthritis, and I really can say that we live in such an exciting world as treatment has vastly improved due to early detection, early treatment, being able to more accurately measure disease activity, and these fantastic new medications. So In rheumatoid arthritis, we're now aiming for remission, and the treatment involves many health professionals, such as physiotherapists, occupational therapists, and podiatrists, without whom I really would not be able to do my job. One of the first-line medications is often steroids that are used as bridging or rescue therapy, and these are very effective, but carry the risk of side effects with long-term use. We do have three broad types of disease-modifying anti-rheumatic drugs that are used. These include conventional synthetic drugs such as methotrexate, and are more targeted therapies such as biologics, adalimumab, and targeted synthetic drugs such as tofacitinib. So I'm going to very briefly focus on the more targeted therapies, and these really have revolutionized treatment for patients with rheumatoid arthritis and other IMIDs. And we have a number of specific targets available, and you've seen previously that different IMIDs have different pro-inflammatory cytokine profiles. And these drugs have different structure in their molecules, which has an implication on how well they work, their pharmacokinetics, but also their safety. So these drugs can be monoclonal antibodies or receptor fusion proteins, and include TNF inhibitors targeting TNF-alpha, IL-6 receptor antibodies, and CD20 antibodies that deplete B cells, as well as targeting T cell co-stimulation. So these agents have a number of different structures, and in part, these different structures is responsible for the pharmacokinetics of their drugs. So it includes chimeric antibodies, where a portion of the mouse antibody is replaced by the human sequence of amino acids, such as infliximab, which is 25% derived from mouse, and rituximab. And then we have recombinant DNA fully human antibodies, such as adalimumab and golimumab, as well as humanized monoclonal antibodies, such as tocilizumab, where there is a small amount of mouse amino acid. These antibodies that are targeted treatments can also be attached to chemical structures that alter their pharmacokinetics, such as certolizumab, which has attached to it a polyethylene glycol that increases its half-life. That means it affects how many times patients need to inject. But there are also fusion proteins that target TNF-alpha, such as etanercept, which is a fusion protein of the TNF receptor and the Fc portion of IgG1, and is therefore not regarded as a monoclonal antibody. And we'll see what effects this may have. And finally, the targeted synthetic DMARDs, which target the Janus kinases. So this comes from the Roman god of doorways. So JAK tyrosine kinases are intracellular signaling proteins that are responsible for activating downstream signal transducer and activator transcription, or STAT proteins that regulate gene transcription. JAK activation relies upon binding of cytokines to type 1 and type 2 cytokine receptors, including pro-inflammatory cytokines that we target, such as IL-6. So what we see with these medications is that they actually stop STAT dimerization, so that it therefore does not translocate to the nucleus, and it affects downstream transcription and production of certain proteins. So the biologics are targeted drugs targeted against these pro-inflammatory cytokines, but they do come with a price tag of up to $10,000 per patient. And in the UK in 2017 to 18, the NHS spent approximately 2.4 billion on these drugs. So the costs are variable with the development of biosimilars, which has helped to bring down the price. These biosimilars are not completely identical to the originator drug, and so there can be subtle or undetectable differences that can occur. So we do see a significant cost to these medications, and on top of that, response is not universal. One reason why people do not respond to these medications is what we call immunogenicity. So this is the ability of a foreign substance to provoke an immune response. And in biologics, we can develop antibodies against these medications, resulting in anti-drug antibody development. The antibodies can be against the mouse part of the drug, or we can develop anti-drug antibodies against humanized therapies such as adalimumab. But as I alluded to earlier, the development of these anti-drug antibodies is less likely with etanercept, which is a fusion protein rather than a monoclonal antibody. And we will have talks as part of this series to explore what effect that has. So these antibodies are mainly IgG and can be neutralizing or non-neutralizing, but they bind to the drug. So they can be non-neutralizing, so not affecting the drug-target interaction, but they can also be neutralizing and bind the active site of the drug. So the drug cannot bind to its site, affecting how well it works or accelerating drug clearance. So there's a number of patient and treatment factors that increase the risk of developing immunogenicity. So again, partly our genetics. This is some work conducted by my colleagues in Manchester, published in Annals this year. References at the bottom of the page, but we see some HLA alleles that are protective, whilst others also increase the risk of formation of these anti-drug antibodies. But there's also treatment-related factors, and my colleagues in Manchester also showed that one of the strongest variables that protect from immunogenicity was not our genetics, but actually was conferred by DMARD chemotherapy, particularly when patients also prescribed methotrexate. So the last treatment-related factor is that we have some biologic drugs that have minimal neutralizing antibodies, such as etanercept. But work from within Manchester has also shown that drug levels can also affect response. So work that we've seen here has shown that higher adalimumab drug levels are associated with response, and when patients develop these anti-drug antibodies, it does have a reduced response. So there's also evidence that higher drug levels in themselves can have complications, which maybe isn't surprising because these medicines are suppressing some of the inflammatory response. So this was a study in inflammatory spinal disease that has shown in the adjusted analysis, higher levels of infliximab are associated with increased risk of infection, almost over 2 times. So we now have this situation where for patients with rheumatoid arthritis, for example, where after receiving 2 different conventional anti-rheumatic drugs, we have a number of different drugs with different targets that we can start. But about 40% of patients will experience a failure of these drugs. We can then switch to a different mechanism of action, a different target, or stay within the same drug target and switch drugs. But all of this really leads to what I call impersonalized medicine, where there's no direction to which drug we should start. We therefore typically start with the least expensive drug or the one which we have more experience with. So these ineffective switches really lead to increased time, risk of side effects with each switch, and uncontrolled disease and increased cost. So in the next lectures, as part of this series, our Inotta colleagues will be talking about how the work that is ongoing in understanding how we can use immunogenicity and drug levels in the future to help guide therapy. So, in summary, these IMIDs are heterogeneous disorders with different target organs. They often share common inflammatory pathways, and there's an underlying theme of loss of self-tolerance and a pro-inflammatory response. The profile of pro-inflammatory cytokines varies by disease, and therefore some of the advanced therapies that we target for these cytokines also vary. But these therapies have revolutionized treatment options, so we've got a vast array of options now, but response is still not universal. So finally, I just wanted to highlight the Inotta short-term scientific meetings, which are these fantastic grants available to facilitate scientists going to another institution in another country. So if you are interested or would like to consider coming to visit us in Manchester, scan the QR code or please get in touch with me.
Thank you very much, James, for an excellent overview of this area. As mentioned before, we will save our questions to the end of the webinar. So please, if you have questions, you can already write them down in the chat or the Q&A window. So before we will let Jill share his slide, I will just want to introduce him first. So he is already prepared. I can see that. So yes, so that leads me to introducing the second speaker of today. It's Gilles Penteau. He's a professor of clinical pharmacology at the Faculty of Medicine in Tours, and he also works in the unit of therapeutic drug monitoring and analytical toxicity at Tours University Hospital in France. He's a physician, and he started as a gastroenterologist before moving into pharmacology. He obtained his PhD at the Karolinska Institute in Stockholm, and he has been working on the pharmacokinetics of therapeutic antibodies since 2001. And he's also head of the French reference medical laboratory for therapeutic drug monitoring of monoclonal antibodies. And his research focuses on the inter-individual variability of the response to monoclonal antibodies using in-house ELISA techniques and population pharmacokinetic and pharmacokinetic pharmacodynamic modeling. So with that, I would like to introduce you to share your slides.
Cannot. Yes. Thank you, Elizabeth. Is it okay for my slide?
It is, yes.
Thank you. So I'm going to discuss differences between therapeutic monoclonal antibodies and small molecules or small drugs. And I will mainly focus on pharmacological differences as the basis of therapeutics. Here are my conflict of interest. So 2 university hospitals receives money from some pharmaceutical industry for my research team. So you know that small drugs are very different from monoclonal antibodies, which are much bigger. And of course, we can expect a different behavior in the body. There are similarities because both are drugs, but there are also a lot of differences in terms of the dose concentration effect relationship. And notably, there are especially differences in the sources of this inter-individual variability in pharmacokinetics and PK/PD. So most monoclonal antibodies on the market are immunoglobulin G, so IgG, and a lot of IgG1. They have 2 FAB portions that binds to the target, and a FC portion, which is responsible for effector functions. So CDR binds to the epitope on the target, and there are sites of binding on the FC portion, binding to Fc gamma R receptors, which are present on immune cells, and on the C1q fraction of complement, and also at the junction of CH2 and CH3, there is a binding site for FcRn, a specific receptor which is responsible of the pharmacokinetics of immunoglobulin Gs. So for all drugs, we know that there is a dose-response relationship, and we may ask if for monoclonal antibodies with a very specific mode of action, there is still this dose-response relationship. So here is an example of tocilizumab, which is an anti-IL-6 receptor monoclonal antibody, and used in rheumatoid arthritis. And you have at the top the ACR20 response and the percentage of responders and the DAS28 score. And you have the responders according to with time treated by placebo in red, with 4 milligrams per kilogram of tocilizumab in blue, or with 8 milligrams per kilogram in green. And you can see that there is indeed a dose-response relationship. And increasing the dose, you may increase the response of the patient. But also, we can see that at this higher dose, you have around 60% of patients who are responders. That means that there is an inter-individual variability in response, and when we need to try to understand why there is this variability between patients. So the best way is to measure the concentration. This is allowed to describe this dose effect relationship in more details. So we can measure drug concentration. Drug will go into tissues. This is a distribution, and among these tissues, there is a site of action of the drugs that will be connected to the effect. Pharmacokinetics is a relationship between dose and concentrations, and the PK-PD relationship is a concentration-effect relationship measured in vivo and in humans. So we define the distribution. The drugs are eliminated, and we quantify this by the clearance. And drugs can be injected or given orally or extravascularly, and then there is an absorption. So what is known for small drugs? For small drug, we know that enzyme of drug metabolism and transporters play a role in absorption and also are very important for drug elimination, for the clearance. And we know that kidney and liver function may influence or may decrease the clearance of the drug. It's also known that demographic factors like body weight, body surface area will influence both distribution and elimination. But for monoclonal antibodies, there is no effect of enzyme of drug metabolism or transporters, and patients with kidney or liver disease don't have any modification in pharmacokinetics. Still, there is an effect of demographics, body weight, and body surface area. So these are examples studied with a two-compartment model, which is a common model used to describe the pharmacokinetics of therapeutic antibodies, monoclonal antibodies. On the left, you have infliximab in rheumatoid arthritis, and on the right, cetuximab, an anti-EGFR, which is used in metastatic colorectal cancer. In both cases, you can see that body weight or body surface area is associated with volume of distribution, so that the volume increases with the size of the patient. And this increase in volume of distribution will lead to lower concentration and then to a decreased efficacy of the drugs. So what are the mechanisms of elimination of monoclonal antibodies? Here, there are three mechanisms. First, there is a non-specific catabolism, which is common to all circulating proteins. So there is an uptake of circulating proteins, and this makes a turnover of protein in the body. But there is also protection thanks to FcRn, and because of this Fc portion, protection of degradation. And the third mechanism is elimination after binding to the target antigen, formation of immune complex or internalization, and then there is disappearance of the therapeutic antibody. The two first mechanisms, non-specific catabolism and protection by FcRn, are non-saturable, at least at the dose, at the concentration of monoclonal antibodies. It's different for intravenous immunoglobulins that saturate FcRn and then can lead to elimination of associated monoclonal antibodies. And on the other side, elimination after binding to the target antigen is also a saturable phenomenon because there is a given amount of target antigen, and that there is not an infinite value of target antigen, and that there is a saturation of this elimination. So how does it work for FcRn? First, there is this catabolism of circulating protein. So in monocytes, macrophages, or endothelial cells, there is a passive uptake of proteins in the serum. This is split pinocytosis. And this endosome progressively have a decrease in pH. And with a pH of below 5.5, there is a degradation of the protein. but it steps in FcRn, which is here in red. FcRn at low pH at 6.5, can bind to the Fc portion, so it can bind immunoglobulins, it can bind small immune complex, and it diverts them from degradation from the lysosome pathway and sends them back to the apical part of the cell. And with a neutral pH, there is a release of immunoglobulins or small immune complex in the circulation. So this is recycling. But FcRn also acts on transport, transcellular transport of immunoglobulins and monoclonal antibodies. And there is a bidirectional transport of IgGs through placenta, as shown in these figures, but also in lungs, in kidneys, in intestines, and other tissues. So I modified a little bit my figure. Now we know that weight, body surface area influences the distribution and not the clearance. And FcRn plays a role in distribution and also plays a role by limiting the non-specific catabolism of antibodies. What are the consequences of this FcRn involvement? The recycling. Monoclonal antibodies have a very long half-life of around 21 days. This means that a loading dose is usually recommended because you know that you need to wait for 5 half-lives to be at steady state. That would mean 15 weeks before reaching therapeutic final concentration. So we need a loading dose. And if you discontinue the treatment, the effect will persist for weeks or months after the last injection. And also there is a specific drug interaction with IVIG, intravenous immunoglobulin, with the saturation of FcRn. And there is also transcytosis. So it means that monoclonal antibodies are not confined to systemic circulation, although it is written in a lot of textbooks. It goes into the tissues. There is specifically this transplacental transfer at the end of pregnancy. And if we measure monoclonal antibodies in the cord blood, in the newborn, we measure concentration which are equal or sometimes higher than that in the mother. And at the blood-brain barrier, FcRn is thought to be involved only in the efflux of IgG from the brain parenchyma to the brain capillaries. So this means that it's difficult to treat with antibody central nervous diseases such as Alzheimer's disease or Parkinson's disease. The third mechanism is target-mediated drug disposition, TMDD. When you give an anti-TNF alpha, for example, monoclonal antibody, it will neutralize TNF and construct an immune complex. But at the same time, TNF will neutralize the antibody. There will be a consumption of the antibody by its target. So a number of papers have studied this, and I can show you the result from a study we performed where we studied the pharmacokinetics of infliximab in ankylosing spondylitis, rheumatoid arthritis, Crohn's disease, and ulcerative colitis. And we use the same ELISA technique in all these patients. And we use the simple one-compartment pharmacokinetic model. And you can see that both for volume of distribution and for clearance, there was indeed an effect of the disease with higher volume of distribution in digestive inflammatory disease and higher clearance than in rheumatoid arthritis or ankylosing spondylitis. So this means that to obtain a given concentration, one should give higher doses in Crohn's disease or ulcerative colitis. So I add this to my figure. So now I have placed the free target antigen because it's a main mode of action of antibodies is to bind and then usually neutralize the target antigen. This target antigen will neutralize in its turn the concentration of the antibody, so it will decrease the concentration, and also it will play a role in distribution in the tissues. And this may lead to a vicious cycle. If the concentration of the antibody in the blood is too low, then there will be an inhibition, a binding to the target antigen, which will be insufficient. And then this high level of target antigen will decrease even more the concentration of the antibody in the blood, and therefore decrease the efficacy of the drug. The other consequence of this target-mediated drug disposition is the nonlinear pharmacokinetics. It can be seen here again with tocilizumab. 2 doses, 4 milligrams per kilogram or 8 milligrams per kilogram. These are concentration on a log scale versus time. And you have the median patients with a solid line and the 5th and the 95th percentile in dotted lines. And the red line corresponds to 1 milligram or 1 microgram per milliliter, which is the threshold for a therapeutic concentration. One can see that for patients with a lower concentration, where this strange behavior of the concentration, an acceleration of decrease of the concentration of the drug with time, this means that with the lower dose, 4 milligrams per kilogram, a number of patients were below this threshold and had this nonlinear kinetics. This is why the 8 milligram per kilogram dose was selected to have a small number of patients below this line and to have as less as possible nonlinear elimination. Nonlinear pharmacokinetics is also observed for small drugs, but very few of them. In fact, the best example is phenytoin, where there is this nonlinear pharmacokinetics. And for monoclonal antibodies, at least in inflammatory disease, there is tocilizumab and eculizumab with a strong nonlinear kinetics. The saturable phenomenon concerns the enzyme of drug metabolism for the small drug and the target-mediated disposition for monoclonal antibody. And for small drugs, the linear pharmacokinetics concentration proportional to the dose are seen at low concentration, and the nonlinear pharmacokinetics, dose-dependent pharmacokinetics, are seen at high concentration. It's the opposite for the antibodies, where linear pharmacokinetics are observed at high concentration and nonlinear at low concentration. And the consequences of this nonlinear pharmacokinetics is toxicity for small drugs and inefficacy for monoclonal antibodies. So the consequences of target-mediated dose disposition is that the dose should be adjusted to the target antigen mass or its biomarker. Pharmacokinetics parameter obtained by non-compartmental approach, which are those that are usually available in the summary of product characteristics, such as the clearance, the half-life, they are dose-dependent. There is not a unique value, but the value varies with the dose. The dosing regimen cannot be modified, for example, by doubling the dose and doubling the administration interval without therapeutic drug monitoring based on measuring the concentration, because we don't know what is going to happen. And the pharmacokinetic model, the pharmacokinetic may be analyzed with a more complex model, with a semi-mechanistic compartmental model, such as what is called the TMDD model. Immunization, as said already by James, is a very important feature that is observed with therapeutic proteins. But I want to insist on one aspect of this immunization, is that the underexposure of the patient increases the risk of immunization. These are results from a study by Denis Muhlmann and Émilie Ducoureau, where we studied rheumatoid arthritis patients, ankylosing spondylitis, and we measure the concentration of infliximab in the patient as early as 2 weeks after the initiation of the treatment. And one can see that patients who will ultimately develop ADA, who will immunize against infliximab, had very low, at least lower concentration at the initiation of treatment. This was observed for both situations. So that it means that, of course, anti-drug antibodies will increase the elimination of therapeutic antibody, but that high concentration of the therapeutic antibody will protect from the development of anti-drug antibodies. And again, there is a vicious circle. Patient with low concentration at the initiation, because probably of high target antigen, will be more prone to develop ADA, anti-drug antibody, and then will even have even more decrease in their concentration. And then this will again explain a lack of efficacy of the drug. So as a tentative of conclusion, I've tried to summarize what I presented and other factors of differences between small drugs and monoclonal antibodies. On the pharmacokinetic side, administration, for small drugs, you can give them by enteral or parenteral route. For mAbs, it's only the parenteral route. For absorption, the extent and rate of absorption of small drug is according to the drug itself and its formulation. In the case of monoclonal antibodies, the absorption is not complete. It's around 60%, and the rate of absorption is very slow. The Tmax is in days, usually around 1 week. Distribution, it's explained by lipophilicity and by ABC, and other transporter for small drugs. And it's explained by FcRn and target antigen amount in tissue for monoclonal antibodies. Elimination, drug metabolism by enzyme, ABC, and other transporters. And for monoclonal antibodies, non-specific catabolism and protection by FcRn. So half-life, usually in hours for small drugs, around 3 weeks for monoclonal antibodies. Drug interaction, there are a number of them with inhibitors and inducers of enzymes and transporters. For monoclonal antibodies, it's only with IVIG because of FcRn, but also with drug acting directly on the antigen because this will indirectly modify the TMDD. Other sources of variability, body weight, body surface area, acting on clearance and volume and only on volume for monoclonal antibodies. Genetic polymorphism of enzyme, liver and kidney function for small drugs, and disease activity because of TMDD for mAbs and also immunization. And those independent pharmacokinetics, it's mostly the case for small drugs, and it's rather unusual for monoclonal antibodies where we need more complex models to describe the pharmacokinetics. And a few words on pharmacodynamics. PK and PK-PD relationship are independent for small drugs, and they are interrelated for monoclonal antibodies. And adverse side effects, they are numerous, can be off-target, toxicity in the liver, in kidneys, in skin, etc. But for monoclonal antibodies, the toxicity is mainly related to the target antigen blockade, which is for anti-inflammatory antibodies, usually the risk of infections. And I will end up by thanking my teams, the research team and the Department of Pharmacology of 2 university hospitals. Thank you.
Thank you, Gilles, for this excellent overview. So I cannot conceal my happiness to have you for this webinar because we have been working for so long, and it's really good to understand that with so many work we have accumulated during the past 15 years. So we are still work ahead of us, but we have accumulated a lot of evidence and a lot of results. So thank you for this excellent overview. And so there are questions. So I see in the chat there's one question to you, Gilles. How fast are monoclonal antibodies eliminated after binding to its soluble target? Or do you by elimination just mean that we cannot measure monoclonal antibody anymore? This is an analytical question, actually.
Yeah, the question is on the immune complex. So how is eliminated the immune complex? Is it the question?
The question is, how can you measure the speed of elimination of a monoclonal antibody? Since when it's bind, if I understand this question, when it bind to the target, you cannot measure it anymore.
No,
so it's more.
No, yes, indeed there are different species. So in the best case, if you have the amount of therapeutic antibody is high enough, then you will saturate this elimination by the target antigen, and then you will have this very nice log linear decrease in concentration, and you have a common 2-compartment model. But then when you start to decrease your antibody concentration and that it comes close to the value of target concentration, then the target takes the lead and then it will accelerate the elimination of the drug. And then you cannot really measure a speed, because if you measure the half-life every hour, then you will see an increase in half-life with time. And then the second question is, it would be interesting to measure all species, to measure the antibody, to measure the pre-target antigen, and to measure the immune complex. Then it's very difficult because usually the ELISA techniques cannot differentiate between the target antigen and the immune complex. And so people who try to measure under treatment, after treatment initiation, try to measure the target, usually they see an increase in target with time, which is not critical, but because in fact they measure both free target and the immune complex.
Okay, so maybe we can take some more questions. I don't see any more question on the Q&A. So I have one question, a very practical question to James. So thank you for your excellent lecture. So you cover a lot of diseases, and then you stress that there are also a lot of progress in treating patients, and it's, yeah, we have a lot of work, particularly in the environmental factors. So I was very interested by what you mentioned on dust and how these environmental factors can trigger the disease. And long ago, so we on my experience, so I've seen so many patients saying that eating this food can trigger something that can modify the disease activity. And we did not at that time consider that it was for real, but now with the microbiota, it's something that we have to pay more attention on. What is your experience? Do you deal with this, especially food, diet? Do you have this question coming from your patient, James?
Yeah, so I think it's fair to say that a lot of people try to modify their diet to see if that can help control their disease. I've not seen a huge amount of evidence to show that it can, in rheumatoid arthritis, for example. And so I think the jury's still out. Not seeing enough evidence doesn't mean it doesn't, but I think the jury's still out.
Okay. Any more questions before we adjourn? Oh, there's a question from thank you, James, for the nice presentation. Could you maybe reflect on the efficacy of different anti-TNF alpha agents in RA from your experience? I also had the opportunity to attend the first ENOTA webinar, and it was mentioned that infliximab was the one with the highest endoscopic remission in IBD, even though it is more immunogenic than adalimumab or golimumab. So which one is the most?
Which one is top trump? So I guess I would start by saying that there's a lack of head-to-head trials. So it's really difficult from observational studies to try and compare each of the different TNF inhibitors. But what we see in rheumatoid arthritis, I can speak to, is that there's this real ceiling treatment of effect, where with every new targeted drug that comes out, there's similar rates of remission and similar rates of ACR responses across them all. Whether it's TNF inhibitor or whether you're looking at the other targets as well. And so my hope for the future is that we can get more clever about this by developing biomarkers that say, don't take this medicine, but try this one instead. But at the moment, there's a real lack of data to say that one TNF inhibitor is better than another. Part of that is because of a lack of head-to-head trials, but it may be that it doesn't exist in rheumatoid arthritis because of this ceiling effect that we see.
Okay, thank you, James. I think we have no more time to take any more questions. But you can liaise with the speakers. I think it's very easy to contact both of you. Maybe Elizabeth, you would like to make some.
Yeah, I just want to thank you, Denis, for being the co-host of this webinar, and of course to our both excellent speakers for today. And yeah, I just want to welcome you all to attend also the upcoming webinars in this series. I wish you a nice evening.
Thank you. Bye.
Thank you.
Thank you.
Thank you. Bye-bye.